So speaking about the GI surgery, the first area we are going to talk about is your esophagus, people. So I want to begin with the, like now we are entering into the systemic surgery. There are some important images and important points you need to discuss. So we'll discuss in this pattern so that you will be having a rapid coverage of subject. So speaking about the GI surgery, we are going to do, esophagus first. Speaking about the esophagus, there are two images of the motility disorders you need to know. So these are the two images. One is this. What is this image? What does this image says? Come on, it looks like something like screw. What is this? Corkscrew. Corkscrew esophagus. This is the corkscrew esophagus. So corkscrew esophagus is seen in. Yeah, someone said the answer before. Come on, you guys. Yeah, DES people. Diffuse esophageal spasm. Diffuse esophageal spasm. So speaking about this diffuse esophageal spasm, so the patient comes with you with the chest pain plus dysphagia, a burning sensation in the pain, chest pain, and ECG, trophy, and everything is normal. So it's a non-cardiac chest pain along with the dysphagia, especially in female. Okay, DES spasm, how the patient presents to you? DES, non-cardiac chest pain, and plus dysphagia, non-cardiac chest pain plus dysphagia in females over males presents to you. Okay, then you have to suspect the dysphagia is a diffuse esophageal spasm, and in the diffuse esophageal spasm, then the patient comes to you with this, and what do you order here? What do you order here? You order the barium study. So investigation of choices. Barium study. And barium study shows what? Corkscrew esophagus. So now you identified the patient with the non-cardiac chest pain and dysphagia. You ordered a barium swallow, and in the barium swallow shows you the diffuse esophageal spasm, which is a corkscrew esophagus. Now, what are the things you can do? You can do either you can manage it medically or surgically. You can manage it medically or surgically. Medically by nitrates and CCBs or anticholinergic you can give. Nitrates, CCBs and anticholinergics you can give. And for surgically you have to give lung esophagomyotomy. Lung esophagomyotomy. Okay, this is a surgical management for the DES. So what are the DES you have to know in terms of your, what are the things you have to know in terms of your DES? Non-cardiac chest pain plus dysphagia, most commonly seen in female. You order them the barium study, and barium study shows. Yes, and you manage them either medically or surgically. Medical management is associated with what classes of drugs? Nitrates, PCBs, and anticholinergics. Surgical management?
Ehlers myotomy.
Ehlers myotomy or lung esophagomyotomy. Okay, lung esophagomyotomy. Okay, speaking about here. Now, speaking about, okay, let me go in here. Okay, this is the DES. So far you know about the DES. Apart from DES, the second important image in the motility disorder is this one. What is this?
This is achalasia cardia.
Achalasia cardia, which is a bird beak appearance. Okay, so achalasia cardia, what is the mechanism? The patient presents to you. How does the patient presents to you? It's a triad of symptoms. What is the triad of symptoms you may see in achalasia cardia? How does the patient present to you? Dysphagia for liquid. Did you write the test or did I erase it before you write? You finished writing test, right? Diffuse esophageal spasm. So I can able to write the, achalasia cardia now, right? Yes or no?
Yes.
Is it okay? Okay, good. So what do we do is the patient is present with the dysphagia for liquid over solid. dysphagia for liquids over solid, along with regurgitation and weight loss. Because of the regurgitation and dysphagia, patient won't eat much. The patient may present with the weight loss. So this is a triad of symptoms. The patient presents to you with dysphagia for liquids and regurgitation and weight loss. So if you do that, you order the patient, what is the investigation of choice? Investigation of choice is esophageal manometry, but you can do one more thing. Manometry, you can do also the barium swallow. If you are doing the barium swallow, what could you see in the barium swallow? In the barium swallow, what are you seeing?
Bird beak appearance.
Bird beak appearance with Hurst phenomenon. Bird beak appearance with Hurst phenomenon. Hurst phenomenon is nothing, just the oozing of the contrast in the stomach. Okay, so you see the beak and then you see the blowing of a beak. That's a Hurst phenomenon. Bird beak appearance, I rather say. So bird beak appearance or Hurst phenomenon you may see in the into Hurst phenomenon, HURST. Bird beak appearance, barium swallow shows. Bird beak appearance. Is this color okay?
Okay, sir.
With Hurst phenomenon. Hurst phenomenon. Okay. So you found that there is a bird beak appearance with the dysphagia, regurgitation, and weight loss. You diagnosed it as achalasia cardia. What is the principle or pathophysiology behind the achalasia cardia, which is one of the important MCQ? What is the pathophysiology? Absence of ganglion cells of Arbuck nerve plexus. Where do you see the Arbuck nerve plexus? Where do you see the Arbuck nerve plexus, people? Come on. Absence of ganglions in Arbuck nerve plexus. Yes. So we have the two types of nerve plexus, which is combinedly called as enteric nervous system or little brain of the gut. What is that? Meissner's and Arbuck nerve plexus. Where do you see the Arbuck's nerve plexus? So you have 4 layers of G80. What are they? What are the 4 layers of G80, people? Faster. Mucosa, submucosa, muscularis externus, and serosa. Yes or no? On the muscularis externus, you are having 3 layers of fiber, and between the longitudinal and the circular fibers, you may have the Arbuck nerve plexus. So, in that Arbuck nerve plexus, the ganglion cells are absent. Then that could lead to what? Absence of ganglion cells of Arbuck nerve plexus could lead to lack of dilatation of your LES. Dilatation of your lower esophageal sphincter, which in turn could result in non-peristaltic contraction. Okay, non-peristalsis or non-peristaltic contraction. Okay, clear about that? So how do you manage the achalasia cardia? So medical management as well as surgical management. Medical management as well as surgical management. Speaking about this medical management, whatever you give for the motility disorders, the DES is same. Nitrates, CCBs, and anticholinergic you give. Okay, CCBs, nitrates, you may give it for the achalasia cardia also. And for surgery, you may do the modified Heller's myotomy. Modified Heller's cardiomyotomy. Heller's cardiomyotomy. Modified Heller's cardiomyotomy with any type of incision. What type of incision? Top-et or door incision we make. With the top-et or door incision we make. Modified Heller's cardiomyotomy with top-et or door incision. Top-et or door incision we make. Nowadays, POEM is also offered. Perioral endoscopic myotomy can also be offered. But mostly surgery, modified Heller's cardiomyotomy we use. Okay, so these are the 2 important images in terms of motility disorder. Okay, clear people? So this one is a DES and this one is a achalasia cardia. So DES, what are the things you have to remember? Just plain for dysphagia patient comes, you order a barium study, you see the corkscrew esophagus, and you can manage it with the nitrates or lung esophagomyotomy. For achalasia cardia, dysphagia, regurgitation, weight loss is the symptoms. Investigations you do, investigation of choice for achalasia cardia is. What's the investigation of choice?
Esophageal manometry.
Yes. Apart from that, you can also do the, what do we call it? Barium swallow, and barium swallow shows bird beak appearance. Bird beak appearance. So what is the pathophysiology behind achalasia cardia? Lack of ganglion cells of what plexus?
Orbic.
Yes. Which can lead to the lack of dilatation of what structure? Lower esophageal sphincter, which in turn leads to non-peristalsis. And the treatment of choice medicine, CCBs and nitrates we can give. And a surgery, modified Heller cardiomyotomy with Toppet or door fundoplication. Sometimes POEM can also be done. Okay. Now the minor one is your jackhammer esophagus. It's a hypermotility disorder. Okay, jackhammer esophagus, which is a hypermotility disorder. Patients present with the dysphagia, orinophagia, and chest pain. Same like a DES. But what the important thing with the jackhammer esophagus is the manometrial finding. What is a manometrial finding you may see in the case of your jackhammer esophagus? Amplitude of 400 mm of G, amplitude of 400, and DCI of diffuse contraction integral of more than 8,000. This is a unique finding, people. Okay, this is the unique finding where you cannot find in other motility disorder. Amplitude of over 400 and DCI of more than 8,000. DCI of more than 8,000. That is a unique finding where you cannot able to find the other things, other motility disorder. So that's why I mentioned it. And overall motility disorders, we use the Chicago classification. If they ask you the name the classification, overall Chicago classification. So with this, we completed the motility disorders of your esophagus. So achalasia cardia, DES, and jackhammer esophagus we have done. Clear? Shall I move on to the next? Yes. Shall I move on to the next? Okay. Next is the diverticular diseases. So speaking about the diverticular diseases, we are having an upper, we are having a mid, and we are having a lower. So upper is also called as a pharyngoesophageal one, which is also called as a Zenker's diverticulum. Pharyngoesophageal one. Pharyngoesophageal one, which is also known as Zenker's diverticulum, which is a false diverticulum. What's the difference between false and true? All the layers are present, then it is a true diverticulum. If any one of the layers are absent, it is a false diverticulum. So in Zenker's diverticulum, the outpouching occurs through the bare area. Okay, bare area, that bare area is known as Killian's dehiscence. Outpouching occurs through Killian's dehiscence. Outpouching occurs through Killian's dehiscence. Occurs through Killian's dehiscence. So technically, Zenker's diverticulum patient, how did they come to you with the case scenario? Old age people. Okay, remember that old age people with tickling sensation in throat. Immediately think about Zenker's diverticulum. Most commonly, the outpouching occurs in Killian's dehiscence, and investigation of choice is barium swallow, especially the lateral view barium swallow. So you can able to find the image. I had the image, but I removed it purposely because they never asked it. Okay, lateral view barium esophagogram, you can do it. So you may see that there is outpouching. Surgery is required. If it is less than 3 centimeter, surgical myotomy you can do. And if it is more than 3 centimeter, you should do the Dolman procedure. That's why I am writing only that name. Dolman procedure you should do. Okay. So Zenker's diverticulum, what are the things? Old age, tickling sensation on throat, the outpouching occurs in Killian's dehiscence, investigation of choices lateral view barium esophagogram, surgery less than 3 centimeter, surgical myotomy we can do, and more than 3 centimeter Dolman procedure along with the surgery you have to do. More than 3 centimeter Dolman procedure along with the surgery. Okay, next is a traction diverticulum or mid diverticulum, which is a true diverticulum, parabronchial diverticulum. Okay, wow. So most common cause of a traction diverticulum is histoplasmosis. Very, 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 very important. Histoplasmosis and non-infectious cause are you can go for the mediastinal fibrosis. If you see any of these two, then you can able to identify this is the most common cause of traction diverticulum or parabronchial diverticulum or mid-esophageal diverticulum. Okay, mediastinal fibrosis, most common cause. Investigation, all the outpouching, so lateral view of barium swallow. Surgery is indicated only more than 20 centimeter. Okay, surgery is indicated only more than 2 centimeter. You will cut off the diverticulum. So diverticulopexy you will do. Okay, diverticulopexy you will do. And epiphrenic or lower esophageal diverticulum, it's a pulsion diverticulum. It's a pulsion diverticulum which is on right side mostly. Diverticulum. And the surgery same, required more than 2 centimeters. So outpouching at Killian's dehiscence. Outpouching at Killian's dehiscence.
Zenka diverticulum.
What diverticulum? Zenka's diverticulum. Which one is a true diverticulum?
True diverticulum.
Traction diverticulum or parabronchial diverticulum? Okay, very good. Which one is a pulsion diverticulum? Pulsion diverticulum. Epiphrenic diverticulum. Okay, very good. Which one is okay, what is the most common cause of parabronchial diverticulum? Most common. Histoplasmosis or mediastinal fibrosis in terms of non-infectious causes. Okay, in terms of parabronchial diverticulum, most common causes histoplasmosis or mediastinal fibrosis. Okay, Dolman procedure is indicated for Zenka's diverticulum. The size is more than
3 centimeter.
Very good. Diverticulopexy or diverticulotomy is indicated for the other diverticulum. For the epiphrenic diverticulopexy, diverticulotomy and myotomy can be used. And for the parabronchial diverticulopexy only used. Okay, these are the things you need to know in the case of diverticular disorders of esophagus. Okay, Killian's dehiscence outpouching la enna diverticulum varum. Which diverticulum will be seen in Killian's dehiscence?
Zenka diverticulum.
Very good. And motility value for a manometry shows the integral value DCA of more than 8,000 indicates what condition? Esophageal manometry shows a DCA of more than 8,000 indicates what? Jackhammer esophagus. Very important, and it's a unique finding. That's why I'm saying it. They have a higher chances of coming in examination. Tickling sensation in throat in old age people.
Junkers.
Most common complication is lung abscess. Because of the aspiration pneumonia, you may see the lung abscess, or perforation and bleeding is also other complications of Zenka's. Okay. And apart from that, what is the investigation of choice for achalasia cardia?
Manometry.
Investigation of choice for abdominal trauma in unstable patient.
Unstably fast. FAST.
Stable patient.
CECT or CT.
Bird beak appearance.
Achalasia cardia.
Diffuse esophageal spasm. What is the barium swallow finding?
Corkscrew esophagus.
Corkscrew esophagus. Corkscrew esophagus. Okay, very good people. Very good. So shall we move on to the next area? That is the GERD. So moving on to the next area, which is the GERD. So speaking of that, retrosternal chest pain with the epigastric pain and regurgitation. Most common causes are reflex esophagitis. Most common causes are reflex esophagitis. And what is the named classification we uses on the GERD? What is the named classification we uses on the GERD? Los Angeles and Savory-Miller classification we uses for GERD. What is the named classification we uses on the motility disorders? Chicago classification. Chicago classification. What is the named classification we uses for GERD?
GERD.
Los Angeles one. Los Angeles classification or Savory-Miller classification. What is the investigation? Ambulatory 24-hour monitoring, pH monitoring is a gold standard one. Very important. Because esophagus, most people used to choose whenever esophagus has come, esophageal manometry is a investigation of choice. No. In terms of GERD, ambulatory 24-hour pH monitoring is a gold standard. In terms of your achalasia cardia, esophageal manometry is a gold standard. In terms of your diverticular diseases, investigation of choices, barium swallow. Each one have a different investigation of choice, and you have to remember each one of them. Don't be confused with the manometry, and don't be confused with the pH monitoring, and don't be confused with the barium swallow. Clear? Any structural abnormalities you
Yes.
want to see, do the barium swallow. Any motility you want to see, the manometry. If you see any problem with the acid, pH monitoring. In simple. Okay. Now, treatment for the GERD, you already know. The medical treatment, we use as a PPIs and H2 blockers. But for the surgery, we are having this variety of surgery, which is very, very important. One is your shoe sign maneuver. Shoe shine maneuver, you pull on the either side of the wrap behind the esophagus, and you should remove it, and you should check the adequate mobility, and you should remove the lack of tension. So Nissan fundoplication 360 wrap and top at 270, Dor 180, Watson anterior 90. So Watson anterior is 90-degree wrap, Dor is 180, top at is 270, Nissan is 360. Very, 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 very important is this degree of wrap. Watson 90, Dor 180, Topet 270, Nissan 360. Okay, which one is a 270-degree wrap? Which one is a 270-degree wrap?
Posterior.
Topet. Which one is the 180-degree wrap?
Door fundoplication.
Watson 1.
90.
Nissan 1.
360 wrap.
360 wrap. If it is an intrathoracic 365-degree fundoplication, that is a Belsey Mark 4. Okay, that's the Belsey Mark 4 in terms of intrathoracic fundoplication. Okay, so this is all about this GERD. This is all about this GERD. Now we move on to the Barrett esophagus. The next one is here, Barrett esophagus. What is the Barrett esophagus? Definition of Barrett esophagus. It's a metaplasia. What is metaplasia, people? What is this metaplasia?
Normal cells convert into another cell.
Squamous cells will be converted in. Metaplasia means change of one cell type to another cell type. Yes or no? That we studied in the pathology cellular adaptation. What is metaplasia? Change of one cell type to another cell type due to the rapid adaptation. So you see there is a problem. Whenever in the long-standing GERD, the gastric content is keep on flowing into the esophagus by regurgitating back. Am I right or wrong? Yes or no? In the GERD, long-standing GERD, we have the constant regurgitation of the gastric content back to the esophagus, if I am right. Yes or no? Now the content of the pH of the gastrum is very high. Yes or no? What about the pH of the esophagus? It's a normal, right? So highly acidic may rupture the walls of esophagus, right? Am I right or wrong?
Yes, sir.
Yes, sir.
So what happens is this esophagus will have a cellular stress, and it will go to the adaptation by changing its cell type. From what type to what type? Normal squamous epithelium to columnar epithelium along with the goblet cell. Very, 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 very important MCQ in terms of the Barrett esophagus is what cell type is changed into what cell type. Normal squamous is changed into columnar epithelium, intestinal columnar epithelium. Okay, so named criteria is Prague criteria. So since it is a columnar cell, squamous cells will undergo squamous cell carcinoma, while columnar cells will undergo adenocarcinoma. So where this Barrett esophagus is happening or metaplasia change is happening, upper esophagus or lower esophagus?
Upper.
Come on, people. Why does the upper esophagus? You are swallowing acid. Are you swallowing acid? No, right?
No.
So it's a regurgitation of GERD from the gastric acidic content is regurgitating back. So technically from gastrum to esophagus is coming. So where does the change is happening? Metaplastic change is happening.
Upper
Now
part.
say, picture yourself three-dimensionally, lower part of esophagus which is connected with the stomach, they are regurgitating back, and the lower part of the stomach is getting converted into metaplasia. Am I right or wrong?
Yes, sir.
See, draw the structure, people. Draw the structure. You see your foot pipe. This is your esophagus, where the primary and the secondary peristalsis is happening. And then you see your stomach here. And then you see your stomach here. This is where your LES is there. So in a long-standing GERD, this stomach content is going upward. So which part of esophagus is getting metaplastic changes? Which part of esophagus is getting this metaplastic changes? Come on, faster. Lower part of esophagus, yes or no? So here it's all squamous epithelium, and because of this cellular stress, this squamous epithelium is converted into columnar. Am I right or wrong? Am I right or wrong?
Yes.
Yes or no? So that's why I am talking about this. With this, you can easily able to manipulate your tumor problem. So this columnar cells will undergo adenocarcinoma, while the squamous cell will undergo squamous cell carcinoma on a long-term basis, or any tumor happening. So most common cause of a esophageal, most common tumor of esophagus is occurring in mid 1/3. Most common cause of most common location of esophagus is occurring in mid 1/3. So what could be the most common cancer? What could be the most common cancer if it is occurring in the mid 1/3?
Lower 1/3.
No, most common location is mid 1/3. If it is a mid 1/3, what is the most common cancer you can see in this condition? Squamous or adenocarcinoma?
Adenocarcinoma.
Adenocarcinoma is seen in lower 1/3. Which one is seen in the middle 1/3? Squamous cell carcinoma. Look at the structure. This is the upper part, middle part, and lower part. Here you are having this regurgitation. Where are you having this regurgitation? Here you are having this regurgitation. Most common tumor location is middle third. When it is a middle third, what could be the most common epithelium which is present in the middle third? Squamous epithelium or columnar epithelium? Are you getting it or not? If you are not getting it, let me know. No problem. I will draw the structure very clearly.
No, sir.
No. Okay, then we put it here. So, understand here, people. Is this your mouth? Am I right? If it's your mouth, okay, this is your mouth. This is your esophagus. And this is your stomach. Am I right?
Yes.
This is the upper esophagus, middle esophagus, and lower esophagus, which is connected with lower esophageal sphincter. Here it is your stomach with the gastric content. With the long-standing GERD, what is the GERD? Gastroesophageal reflux disease. So from the gastrum to the esophagus, the reflux is happening. So most common location affected in the GERD is what? Upper or middle or lower 1/3? Lower 1/3. Very good. So keep on this lower 1/3 is undergoing the stress, while the entire esophagus is lined by squamous cell. Okay, so because of this keep on increasing in the stress, the squamous will be converted into columnar. In what condition? Barrett esophagus. The squamous will be converted into columnar in what condition? Barrett esophagus condition. So Barrett esophagus is clear?
Yes, sir.
Is the Barrett esophagus is clear?
Yes, sir.
Okay, very good. So now coming to the cell types. Squamous cell and columnar cell. Squamous gives rise to, if it is undergoing a tumor, squamous cell carcinoma, while this columnar will gives rise to columnar adenocarcinoma. Okay, now coming back to the esophageal cancer, most common site is middle 1/3. In the middle 1/3, what type of epithelium is a common epithelium you may see?
Squamous.
Squamous. So what type of cancer will be seen in the most common cancer?
Squamous cell cancer.
Squamous cell cancer. So most common esophageal carcinoma is squamous cell carcinoma worldwide. Okay. Now, if they ask you specifically, what is the most common cancer in the lower 1/3 associated with Barrett esophagus? associated with Barrett esophagus? What could be the cancer? Most
Common.
common type of cancer in lower one third associated with Barrett esophagus. What is the change is happening in Barrett esophagus? What type of cell is converted? Squamous will be converted into what side?
Columnar.
Columnar. Now this columnar cell is undergoing tumor that is associated with the Barrett esophagus. What type of cancer you may see?
Adenocarcinoma.
Adenocarcinoma. Very good, people. Adenocarcinoma. If you know this, you can easily answer the most common tumor of esophagus in this thing. Okay, most common type of cancer. Most common tumor of esophagus is leiomyoma. Benign tumor is leiomyoma. Okay, you should remember that. Leiomyoma is the most common tumor. Most common tumor. Most common malignant tumor. Most common malignant tumor. What is the most common malignant tumor?
Adenocarcinoma.
Middle one third is the most common location, no?
Yes.
What will be the most common tumor? Squamous. If the most common tumor in the lower one third associated with the Barrett esophagus, Nikita. That's it. Adenocarcinoma. So all the investigation of choice in terms of tumor is endoscopic biopsy. Okay, investigation of choice in terms of tumor is endoscopic biopsy. While for the Barrett esophagus, you may do the adenocarcinoma progression. In those cases, you will do the esophagectomy. And apart from that, dysplasia may happen in a high grade and low grade. High grade dysplasia, you can do ablative therapy, and low grade, you can do follow up 1 year. If there is no dysplasia, follow up 2 to 3 years. Okay, if there is no dysplasia, follow up in every 2 to 3 years. Okay, what is the criteria for Barrett esophagus? Prague criteria. What is the criteria for GERD?
Los Angeles.
Criteria. What is the criteria for motility disorder? Chicago criteria. Investigation of choice for motility disorders? Esophageal manometry. Investigation of choice for diverticular diseases? Barium swallow. Investigation of choice for GERD?
24 hours ambulatory.
24 hours ambulatory pH monitoring. Investigation of choice for esophageal tumors? Endoscopic biopsy. Another?
Yes.
Endoscopic biopsy. Okay, now we are talking about the tear. So speaking about the tears, there are two types of tears. One is the Mallory-Weiss tear and Bower-Hoff syndrome. So Mallory-Weiss tear is due to unrelaxed cardia, people. Cardia of the stomach will become unrelaxed. So you may have the content which has been staying in the long time and your esophagus will get ruptured. Okay, so patient may have the hematemesis with the line of blood streaks. So patient may have the vomiting. Consider this is a vomitus, and you may have the streaks of blood in the vomitus. That is so called as Mallory-Weiss tear. That is so called as Mallory-Weiss tear. And in the Bower-Hoff syndrome, it is against the closed glottis, vomiting against the closed glottis, and the Bower-Hoff syndrome is a serious one. Okay, it is spontaneous onset, and you may see the macula triad and Naclario V sign. Very, 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 very important. Macula triad and Naclario V sign. Okay, macula triad and Naclario V sign you may see in the case of your Bower-Hoff syndrome. Okay, so what is this Naclario V sign? What is this Naclario V sign? Come on, people. What is this Naclario V sign? What is this Naclario V sign? Faster, faster. What is this Naclario V sign? There is a V sign. You may see it in the X-ray. At what position you may see the V sign?
There's a
At
air.
what position you may see the V sign? Yes. Air and where?
Costophrenic angle.
Costophrenic angle or cardiophrenic angle? Costophrenic angle or cardiophrenic angle? Here, this is an aclario V sign. You see the V sign along with the cardiophrenic angle. Costophrenic angle will be on that corner. Okay, this is a cardiophrenic angle. What is this? Cardiophrenic angle. You see the V sign, air and cardiophrenic angle. That gives you a aclario V sign. Okay, that CP angle is cardiophrenic angle, not costophrenic. Okay. And macular striate, what are the symptoms of macular striate, people? Go ahead. What are the symptoms of macular striate? Vomiting, chest pain, and subcutaneous emphysema. Very, 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 very important. Okay, vomiting, chest pain, and emphysema. Subcutaneous emphysema is your macular striate. Okay, is your macular striate. What is a Beckwith striate? We studied that in drama. I taught you with the Beckwith triad and lethal triad. What is the Beckwith triad? What is Beckwith triad? Faster people, you should have seen it. Takkana solno, rib fracture. I give you the clue. Rib fracture. Rib fracture. Rib fracture. Helame vittachu. Next. Come on, faster. Beckwith triad. Sollungappa. You don't remember? Rib fracture, diaphragm rupture, and pelvic fracture or spinal fracture is your Beckwith triad. Okay, Beckwith triad is rib fracture, spinal fracture, or diaphragm rupture. Or what? Diaphragm rupture. Okay, what is this lethal triad? I told you to remember with the CHA, cha. What is lethal triad? Lethal triad is an important MCQ. Clinical lethal triad nariya paapinga. So what is a lethal triad? Coagulopathy, hypothermia, and acidosis. Cha, CHA. Now tell me what is macular triad? Vomiting, chest pain, and subcutaneous emphysema. Vomiting, chest pain, and subcutaneous emphysema. Boyer-Hoff syndrome is an emergency condition where you have to take them out for the surgery. So we have done with the tumors, we have done with the Barrett esophagus, we have done with the GERD, we have done with this, we have done with this motility disorders, we have done with this dysphagial disorders. Now we are going to talk about the last area, congenital conditions of esophagus. Speaking about the congenital condition, hiatus hernia, type 1 is sliding, type 2 is paraesophagus or rolling, and type 3 is type 1 and 2 mixed, and type 4 is stomach and other structures that can herniate through the hiatus. Okay, that is a type 1, 2, 3, 4. And TEF, tracheoesophageal fistula, we are having a type A, type B, type C, and a type E, till type A to E. A, B, C, D, and E will be there. While the most common type is a type C. And you may see there is a esophageal atresia along with the distal tef. Esophageal atresia along with the distal tef. Sorry, here. CAB. Sorry. Esophageal atresia with the distal TEF is a type C. And H type of your thing is type E. H type fistula is your type E. Okay, so regurgitation, coughing, cyanosis, choking with the polyhydramnios and Down syndrome, you may see tracheoesophageal fistula. Most common type is type C, H type is type E. Okay, then vectoral anomalies, vertebral anomalies, anal atresia, CVS, TEF, and renal anomalies. So I had seen one patient, okay, one baby in a pediatric unit with this TEF. Okay, so TEF is an emergency where you have to place it in the pediatric ICU. The patient is having this, choking, cyanosis, and all. We have taken an X-ray and it showed a TEF, and we have placed him. So what is the further assessment you have to do is you have to check for the vectoral anomalies, because TEF is mostly associated with vectoral anomaly. What are the vectoral anomaly? What are the vectoral anomaly?
Vertebral anomalies, anal
Mhm.
atresia,
Mhm.
serious defects, and
Mhm.
trichoesophageal
Yep.
defects.
And renal anomalies and limb anomalies. What is the most common mistake the people makes is instead of renal anomalies, they put you on a rectal anomalies. Okay, most common MCQ twist they ask in a vectoral anomalies is instead of renal anomalies, what they give you as an option? What they give you as an option instead of renal anomalies? All of the following comes under vectoral anomalies except it will be your common question. And what will be the twisted answer here? Instead of renal, they give you the rectal. Instead of renal, they give you the rectal. And you people consider a VACTR and you don't read a rectal or renal difference. You basically don't think rectal will not be the part of the vectoral anomalies. Am I right or wrong? Sometimes the starting letter will be the similar. Sometimes the ending letter will not be the same. A good start cannot always be a good ending too. Okay, you should be having a consistency. Okay, next is a dysphagia lusoria. Dysphagia lusoria is associated with aberrant right subclavian artery. Only word you should remember in terms of dysphagia lusoria. You see dysphagia lusoria, immediately you will see the next word. What is the next word? What is the next word you have to see in terms of dysphagia lusoria if you see?
Aberrant right.
Aberrant right subclavian artery. Aberrant right subclavian artery you have to see. Okay. So next is the stomach and duodenum. So speaking about the stomach and duodenum, people, we go for the stomach and duodenum peptic ulcer disease. What is the most common site of a gastric ulcer? Lesser curvature. Okay, straight MCQ. What is the most common site in a gastric peptic ulcer disease? Lesser curvature. Duodenal, it's the first part. Okay, pain relieved by vomiting is seen in. Pain relieved by vomiting is seen in gastric. Pain relieved by food is seen in. Relieved by food is seen in duodenal. Oh, here it's a D. Everybody is tired. Are you people tired? Hmm? You can say me. Are you people tired?
It's okay. Please continue.
Mm-hmm. Okay, next is a H&M ratio. H&M ratio for peptic ulcer disease would be 60 to 40. And here it's a reverse, 40 is to 60. Okay. And patient, because of the pain relieved by vomiting and pain is not relieved by food, the patient will be ill-built because he's scared that it will pain a lot. So he won't eat anything. It will be ill-built. And here the pain is relieved by food. The patient often eats more. So the patient will be obese in this kind of a GERD. Sorry, in this kind of a peptic ulcer disease. Okay, and then tenderness is seen in the epigastric. And here you may see it in the duodenal point. Duodenal point. And the malignancy, it should be 0.5 to 5%. And here there is no malignancy risk. Surgery, gastrectomy. Here is a truncal vagotomy. Gastrectomy, and here it's a truncal vagotomy. Truncal vagotomy. Okay, this is a peptic ulcer disease, people. So speaking about this peptic ulcer disease, most common site is duodenum. Most common site in stomach is lesser curvature. Pain relieved by vomiting is gastric. Pain relieved by food is your duodenal. While gastric have a malignancy risk, while duodenal do not have malignancy risk, and most of them are H. pylori associated. H. pylori associated gastritis is associations are pretty important because the morphology you will study that in the case of your what do we call it microbiology, like it is a lophotrichus, urease positive, catalase positive, oxidase positive, it grows in a spirous medium, and all those things you will study in microbiology. Here you will study the associated condition. One of the very important is type B gastritis. What is a type A gastritis, people? This is a type B gastritis. H. pylori is associated with type B gastritis, while type A is autoimmune atrophic gastritis. Have you ever heard pernicious anemia? Am I right? That is a type A. This one is type B. Type B gastritis is associated with H. pylori. Classic MCQ. Okay, apart from that, H. pylori is associated with the cancer stomach. peptic ulcer disease, as we see. Apart from that, H. pylori is associated with the maltoma and non-nuclear dyspepsia, but that is not necessary. Three things: type B gastritis, cancer stomach, PUD. Okay. So which type of gastric ulcer is relieved by vomiting? Fast. Which type of gastric ulcer is relieved by vomiting? Sorry, which type of peptic ulcer is relieved by vomiting? Gastric. Relieved by food.
Duodenal.
Which one is associated with, which type of gastritis is associated with the H. pylori infection?
B. Type B.
Okay. Which one is autoimmune associated gastritis?
Type A.
What are the associations of H. pylori?
Association with peptic ulcer disease, maltoma, and stomach cancer, and
type B gastritis. Which one is having a malignant risk? Gastric peptic ulcer or duodenal peptic ulcer?
Malignant.
Mostly gastric ulcer. It's a 0.5 to 6%. 5 to 6%. Okay, 5% is a answer here. 5 to 6% you may see. Okay, and apart from that, there is only 30 slides, people, so don't worry about them. So most common complication of gastric ulcer is perforation, while duodenal ulcer, it is bleeding. Most common artery which bleeds in gastric ulcer, this is important. Gastric ulcer, what is a bleeding artery? Left gastric artery, people. And duodenal artery, what is a bleeding artery? Duodenal ulcer, gastroduodenal artery. Okay, this is important. Write it down as a note. What is the most common cause of death in peptic ulcer disease? Bleeding. Gastric ulcers, what is the source of artery in a bleed? What is the source of artery in a bleed of gastric ulcer? Left gastric artery. While in terms of duodenal ulcer, duodenal artery. Very good. So surgery will be emergency in terms of perforation. Okay, for a gastric patient, stable cases, emergency, you can do the distal gastrectomy plus Billroth 1. Unstable cases, you can do the omental closure. Unstable cases, you can do the omental closure. And duodenal ulcer, less than 1 centimeter, primary closure can be done with the Graham's patch. And more than 3 centimeter, you may require a omentum or jejunal serosal excision. Okay, omentum or jejunal serosa will be used for the closure, so it will be excised and used for the closure. Okay, so this is a surgical management. So perforation, gastric and duodenal. Stable patient, gastric ulcer, distal gastrectomy plus Billroth 1. Unstable cases, omental closure. Duodenal, less than 1 centimeter, primary closure along with the Graham's patch. More than 3 centimeter, omentum or jejunal serosa is used for closure. While the GU, truncal vagotomy will be used. Truncal vagotomy will be used. Okay, it could be with the gastrojejunostomy, or it could be with the Heinke-Mikulis pyloroplasty, or it could be with the highly selective vagotomy. But GU, you will do the truncal vagotomy. Okay, truncal vagotomy will be used. So this is the important one. Apart from that, complication, dumping syndrome. So food accumulates is so called as dumping syndrome. Increased PCV is used for diagnosis. Treatment is octreotide. Treatment is octreotide for yearly. Diagnosis of blood sugar is seen in late dumping. Treatment is also octreotide. So any dumping syndrome, you directly choose octreotide as a treatment of choice. The only problem is yearly, immediately you will see the effect, while late dumping syndrome, you will see after 2 hours. Okay, so simply speaking, you may see small intestine filled with the food early. Small intestine filled with the carbohydrate load. Sorry, body is filled with the carbohydrate load. That is a late dumping syndrome. Okay, so apart from the tumors, most common type is tubular adenocarcinoma. Signet ring cell is seen in Krukenberg tumor. Very, 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 very important MCQ. Okay, signet ring cells are seen in Krukenberg tumor. Okay, named classification are Barman and Lauren and Seward. Apart from that, you may see the Troyson sign, involvement of your left supraclavicular node. Another important MCQs. Okay, treatment. For operable case, you can do the Billroth surgery. Inoperable case, palliative care. Okay, inoperable cases, you have to do only the palliative care. Ingestion of hairs, trichobizar. Vegetations, it's a phytobizar. Okay, ingestion of hair, it is a trichobizar. Vegetation, it is a phytobizar. I had seen there is a picture of Rapunzel syndrome, but it was missed. Okay, it will be like this. The stomach and intestine will be filled with the hairs. Stomach and intestine will be filled with the hairs. That is a Rapunzel syndrome. And the tumor, last tumor is GAST. It is arising from intestinal cells of Kajal. Most common symptom is bleeding. Investigation of choice is CECT. Okay, these are all kind of like a low yield people. That's why I'm going fast. Don't worry about that. I'm not rushing because of time. I'm rushing because it is not much important. Only the signet ring cells, Brukenberg tumor, Trauser sign, involvement of left supraclavicular node is there. And for GAST, investigation of choice is CECT. Okay, investigation of choices, CECT. Next is a CHPS, congenital hypertrophic pyloric stenosis, where in the barium male, what sign you will see on barium male? படிச்சிருக்கீங்களா CHPS? What sign? What sign? What sign? சொல்லுங்கப்பா.
Double track sign.
Very good. Double track sign. இன்னொரு sign, or also known as double track sign, or one more sign will be seen. String sign. We used to call that as string sign. Either double track sign or string sign is seen in CHPS. And the surgery would be Ramstead pyloromyotomy. What is the surgery?
Ramstead pyloromyotomy.
Ramsted's pyloromyotomy. Myotomy we will do. Okay. And for duodenal atresia, what is that? Associated with Down syndrome. X-ray shows. What is the X-ray sign? I couldn't able to find a picture, but maybe I will put it in later to you people. I will share it. What is the X-ray shows? The sign name?
Double bulbs.
Double bubble sign. So this bubble signs are seen in all type of atresia people. So single bubble sign is seen in
Styloric.
Single bubble sign is seen in esophageal atresia, double bubble duodenal atresia, and triple bubble it's jejunal atresia. Okay, jejunal atresia you may see the triple bubble, duodenal you may see the double bubble, single bubble esophageal or gastric atresia, upper gastric atresia you may see single bubble sign. Okay, treatment is duodenostomy. Okay, so this is all about the stomach. And speaking about the small intestine, duodenum, you may have a diverticulosis, adenoma, and atresia. Adenoma and atresia. And the jejunum, you may have angiodysplasia, Peutz-Jeghers syndrome, and jejunal atresia, where you may see the triple bubble sign. And ileum, you may see the paralytic ileus, carcinoid syndrome. Carcinoid syndrome is associated with what elevation levels? Biochemistry or maybe this, what do we call it, pathology. Carcinoid syndrome, what levels will be elevated? What is the finding? Yes, someone said some answers. What is that?
Steroid.
Carcinoid syndrome is a excessive serotonin producing tumor. When it is excessive serotonin producing tumor, what levels in urine will be seen? Carcinoid syndrome, excessive serotonin producing tumor. What levels of urine? Elevated levels of what in urine? You have to say, because it's a previous year MCQ. It has been asked 2 times in the past. Not in surgery, but in other kind of pharmacology or biochemistry. They will add it. Or maybe they will add it in the pathology. 5-hydroxy indole acetic acid. What level will be seen? 5-HIAA, 5-hydroxy indole acetic acid levels will be elevated. Okay. Clear? Note it down in the bracket. Elevated 5-HIAA levels in urine. And terminal ileum, you may see TB, Crohn's and adenoma. TB, Crohn's and adenoma. TB Crohn's and adenoma. Okay, fine. I got this. So here we are going to do two differentiations. With this two differentiation, we will be wrapping up our GAT. With these two differentiations, we will be tapping up our GAT. One is a difference between FAP and HNPCC. FAP, the defect is chromosome 5, while here the defect is in the microsatellite instability. This was asked several times in FMGE people. Microsatellite instability was asked several times in FMGE. Okay. Then most commonly associated with the boy or male, most commonly here associated with the female. Okay. And here you can do the prophylactic colectomy. Prophylactic colectomy. But here we have to wait till the carcinoma will have to develop. Wait till the CA develops. Okay. CA develops. So it could be classified as what do we call it? Two types of CA. Okay. So one is your Lynch 1 and Lynch 2. Lynch 1 and Lynch 2. Lynch 1 is CRC only, colorectal carcinoma only, while Lynch 2 is CRC plus extraintestinal CA also. Extraintestinal CA2. Intestinal carcinoma also. Here the named criteria. Here what is the named criteria for FAP? Spigellin criteria. While here it's there are too many. What are they? Give me one. What are they? Give me one named criteria for HNPCC. Give me one. You studied surgery already. This is just revision. Bethesda criteria, or you may also see the Amsterdam criteria. It's all the city names you have to remember. Amsterdam's criteria you see in the HNPCC. Okay. And apart from that, you may see the respective procolectomy with the ilioanal anastomosis. Here we do respective procolectomy. Wherever it is damaged, we do the procolectomy with ilioanal anastomosis. Ilioanal anastomosis we do. And here we do the total colectomy. Here we do the total colectomy. Okay, this is FAP and HNPCC. And apart from that, Crohn's and ulcerative colitis. This is the next one. So Spigellin criteria, FAP. Amsterdam criteria, HNPCC. Okay, and Chicago classification. Chicago classification. Sounds like everybody is trained. Los Angeles classification. Wake up, people. Los Angeles classification. GRD. Okay. Apart from that, lucid interval is seen in
EDH. Pleural hematoma. Hemorrhage.
Worsening headache. SAH. Biconcave opacities. Concave opacities.
Abdural.
SDH. Okay. Apart from that, double tract sign. Double tract sign. சொல்லுங்கப்பா, என்னப்பா சொல்ல மாட்டேங்கிறீங்க? டபுள் ட்ராக் சைன் இப்பதானே பார்த்தோம். CHPS. டபுள் பபிள் சைன். Lawrence classification. Adenocarcinoma. Signature cell. Krukenberg tumor. Investigation of choice for GAST. சொல்ல மாட்டேங்கிறீங்களே. CECT. Elevated 5 HIAA levels. Carcinoid syndrome. Very good, very good. Rupture of berry aneurysm.
SDS.
Rupture of berry aneurysm.
Subarachnoid.
SAH இல்லையா SDH ல bridging vein தான் turn ஆகும். ஓகேவா? Malignant risk, what type of peptic ulcer you may see? Gastric or duodenal? Malignancy risk is seen in gastric or duodenal peptic ulcer?
Gastric.
Gastric.
Type B gastritis is associated with Type B gastritis is associated with H. pylori infection. Type A is associated with
Autoimmune.
autoimmune. Perforating artery or bleeding artery in gastric peptic ulcer diseases. Bleeding artery in gastric peptic ulcer disease. Yeah.
Left gastric.
Left gastric.
In case of duodenal.
Gastric duodenal artery.
Most common complication of gastric ulcer. Perforation. Duodenal is bleeding. Okay. Perforation is gastric and duodenal is bleeding. Okay. Which one is a H type TEF?
Type C.
Type E. Most common type is type C. H type is type E. Dysphagia lusoria is associated with
Right aberrant.
Apparent right subclavian artery. Subclavian artery. Most common type of esophageal tumor in lower 1/3 associated with Barrett esophagus.
Adenocarcinoma.
Adenocarcinoma. What is the Mechler's triad?
Vomiting.
Chest pain, subcutaneous emphysema. Vomiting, chest pain, and subcutaneous emphysema. 90-degree wrap is what? What is the name of 90-degree wrap? The esophageal surgery. Watson. 180.
Nissan is 360.
Nissan 360. 90-degree is
Nissan fundoplication.
Nissan is 360, man. What is the 90-degree wrap?
Okay, 90.
Watson.
What's the 90?
180.
180 is a door.
270. Top head. And the 360. Nissan, and if it is an intrathoracic, it's a Belsey Mark 4. It's a Belsey Mark 4. DCA of more than 8,000. Jackhammer esophagus. Unique points. Neclario V sinus seen in Boerhoff syndrome. Investigation of choice for esophageal cancer. Endoscopic biopsy. What is the sign? Troyes sign. What is the sign called as Troyes sign? Involvement of what nodes? Left supraclavicular nodes. Left supraclavicular nodes. Okay. Last one, important table. Definitely a question table. Okay, definitely a question table. Very, 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 very important table. Crohn's and ulcerative colitis. Crohn's and ulcerative colitis. It's a ASCA positive. It's a ASCA positive. It's a P-ANCA positive. It's a ASCA positive and ulcerative colitis is P-ANCA positive. This one is curable and bimodal distribution. That is early age and old age. Okay, this one occurs in the children and old age people. And this one is a, what do we call it? This one occurs in the old age only. Occurs in old age and incurable. Okay, this one, the lesions will be skipping or some part. So that's why we used to call that as a regional ileitis or skip lesion. And here the lesion will be Continuous, that's why we used to call that as backwash ileitis. Continuous, that's why we used to call that as a backwash ileitis. Okay, va? Ileitis. And here, most common location, terminal ileum. Here there is no specific most common location. It occurs all over the intestine. Okay, here you may see the non-caseating granuloma. Non-caseating granuloma. And here you may see this crypt abscess. Here you may see this crypt abscess. Here you may see the non-caseating granuloma. Here you may see the cobblestone appearance. And here, what do you see? Cobblestone appearance here. What appearance will be here?
Lead pipe.
Lead pipe appearance will be here. Okay. Here you may see the association with PSC, primary sclerosing cholangitis. And here you may see association with the ankylosing spondylosis and arthritis. Ankylosing spondylosis and arthritis. Arthritis. That's why we used to have that this HLA-B27. What are the diseases associated with HLA-B27? Medicine people. What are they? HLA-B27 associated diseases. Shoot me within 10 seconds.
Ankylosing spondylitis, Rett syndrome.
Yes, then only two. You should remember the first aid for USMLE has this fantastic mnemonic called as PAR. I always remember. Psoriatic arthritis, ankylosing spondylosis, inflammatory bowel disease, and Rett syndrome or reactive arthritis. Okay, Rett syndrome or reactive arthritis. This is so called as PAR. PAR is always associated with HLA-B27. You can also remember with the PAR. What are they? P stands for
Psoriasis.
psoriatic arthritis. Psoriatic arthritis. And then A stands for ankylosing spondylosis, where you see the bamboo spine. And I stands for
Inflammatory bowel disease.
yes. And R stands for Rett syndrome or reactive arthritis. Rett syndrome or reactive arthritis. Okay. And you may see the collar button ulcer also in the ulcerative colitis. Collar button ulcer. Okay. And here you may see the Vienna classification for Crohn's disease. Vienna classification for Crohn's disease. And the treatment is symptomatic for both. Treatment is symptomatic. Here you may do sometimes total procolectomy along with ileoanal anastomosis. We may do the total proctocolectomy along with ileoanal anastomosis. Along with ileoanal anastomosis. So this table is very, very important, people. You should not forget. Okay, 5-star rated table. Crohn's, ASCA positive is seen in. ASCA positive is seen in Crohn's. Lead pipe appearance is seen in.
Ulcerative colitis.
I will say you the finding. You say me whether it's Crohn's or ulcerative colitis. Is that okay?
Okay.
Okay, very good. So, which one is the non-curable one?
Ulcerative colitis.
Skip lesions are seen in.
Crohn's disease.
Occurs in younger generation or young people.
Crohn's.
Crypt abscess is seen in.
Ulcerative.
Ulcerative colitis. PSC is associated with.
Ulcerative colitis.
String sign of Cantor and cobblestone appearance.
Crohn's disease.
Backwash ileitis.
Ulcerative colitis.
Ulcerative colitis. Non-caseating granuloma.
Crohn's disease.
Disease.
Ankylosing spondylosis association.
Crohn's disease.
Crohn's disease. HLA-B27 association.
Crohn's disease.
BRCA association. Crohn's. Okay, because ulcerative colitis will be on chromosomal 12. Okay, if you want to write it down. BRCA association, both BRCA 1 and 2, and here you may see the chromosome 12. Okay, so BRCA 1 is associated with what chromosome? BRCA1 is associated with what? And BRCA2 is associated with what chromosome? Previously, you have studied the breast surgery, no? Sorry, breast cancer, no? Associated with the BRCA, no? Yes or no? Have you studied or not?
Yes, sir.
BRCA1 is associated with what chromosome?
Is chromosome 13?
Okay, I will tell you an easy way to remember. Okay, there is two chromosome which is associated with the BRCA. One is 17, another one is 13. Okay, there are two chromosome which is associated with the BRCA. What are they? 17
17
and
and 13.
13. Okay, I used to remember it like a 1, 2, 3. Okay, if you take a 2, which is a BRCA2, then you get,
1, 3.
if you take out in a 1, 2, 3, if you take out a 2, what you get?
1, 3.
That is a BRCA2. So what will be the BRCA1?
13.
BRCA1 17.
BRCA1 is
17.
17q, while BRCA2 is
13.
13Q.
13q. That is a short arm of your 13 chromosome. Okay, you should remember in this way. I used to remember in this way, but if you find anything easier, you can remember in that way also. 1, 2, 3, that is a BRCA2. If you remove the 2, you will get 13. BRCA2 is 13 and BRCA1 is 17. Okay, especially if they are asking you Q or L, you should use the Q. Sorry, P or Q, you should use the Q. Okay, P is a long arm, Q is a short arm. They can ask in any type. Okay, Crohn's and ulcerative clear? Crohn's and ulcerative is clear? Is Crohn's and ulcerative clear? Okay.
Yes, sir.
So, okay. Sure. So, apart from that, we may have this liver. So, speaking about the liver, you need to know the Coinard numbering. So, you know the Coinard numbering already, right? So, this is a Cantle line, which is an imaginary line, which is passing from what to what? IVC to gallbladder. Cantle line passes from IVC to gallbladder, which separates the right and left liver. So you have this one first lobe on the posterior surface, which is so called as a caudate lobe, where it drains directly into IVC. It drains directly into IVC. That's why the hypertrophy of the first lobe or the first caudate lobe is seen in. Hypertrophy of caudate lobe is seen in what syndrome? Very important. Is seen in Budd-Chiari syndrome. Budd-Chiari syndrome or Budd-Chiari syndrome, however you pronounce it. Okay. Then the first one is a caudate lobe. The second one, 2, 3, and 4A and 4B. And you may have this 5, 6, 7, 8. So 4A and 4B combinedly called as quadrate lobe. 4 is so called as quadrate lobe, while 1 is so called as a caudate lobe. Caudate and quadrate lobe. Caudate lobe hypertrophy is seen in Budd-Chiari syndrome, while quadrate lobe contains 4A and 4B. So this is a right and this is a left. Left hepatectomy. Now tell me, which one is a left hepatectomy? What are the segments you remove? Left hepatectomy. What are the segments you remove? Come on, people. You remove the entire left portion. What are the segments you remove? 2, 3, 4A and 4B. Correct? Am I right or wrong? Similarly, right hepatectomy. Right hepatectomy.
6, 5, 7, 8.
5 to 5, 6, 7, 8. Right hepatectomy, you may remove 5, 6, 7, 8. Now here comes the extended left hepatectomy. Extended left and extended right. Extended left hepatectomy. That means you take this portion also. What is that? Extended left hepatectomy. What is that? 2, 3, 4, and 5. Then what? 2 to 2, 3, 4, 5, and then
8, 5.
most people make this mistake. 2 to 6 they write. But what is the extended left hepatectomy segments removal? 2 to 5 along with the 8. And similarly, what this one? Extended right. Extended right goes from very easy. 4A and 4B is here, no? You take out the 4A and 4B. So you may get it like 4 to 8. 4, 5, 6, 7, 8. Okay, 4, 5, 6, 7, 8 on the extended right hepatectomy. 2, 4, 5, 2, 2, 3, 4, 5, and along with 8 on the right, extended left hepatectomy. Well, left hepatectomy 2 to 4, right hepatectomy 5 to 8. Clear? Coinard numbering and the coinard thing. Clear about that? Yes, people?
Yes, sir.
Yes, sir.
Okay. Then you have this liver abscess. Speaking about the liver abscess, there are 3 types of liver abscess. One is a pyogenic, amoebic, and hydatid cyst. So, hydatid cyst. So, pyogenic, most commonly associated with the bacteria, especially E. coli. Which one? E. coli, Staph aureus, Klebsiella. Mostly associated with the pyogenics, so fever. And it will be a multiple or it may be solitary. It's a 50-50. So I rather pick a lesion as a solitary abscess or multiple abscess. Multiple abscess will be there, and the treatment is aspiration. So pyogenic is very easy. Bacterial infection, you may see the fever and you may see the multiple abscess, and the diagnosis is by blood culture, obviously. Blood culture, and the treatment is aspiration. Along with blood culture, if some organism is showing up, you need to initiate the
Antibiotics.
okay, that's it. And amoebic, what could be the organism? Entamoeba histolytica. Okay, Entamoeba histolytica will be the organism. Is my handwriting is okay, or because I'm running in a running handwriting? Is it okay? Organism is histolytica, mostly solitary lesion. It's a solitary lesion in amoebic. Okay, diagnosis is serology and treatment is metrogel, anti-amoebic. Okay, that is a metrogel. Okay, and hydatid cyst organism, you should say, because it is important, you might have covered in surgery. What is the organism causing hydatid cyst? What is this, people? You have to say faster.
Grano.
That's it. No.
Echinococcus granulomatous. What is this?
Echinococcus granulomatous.
Granulomatous. So mostly associated with abdominal pain. And there are 2 things which is associated here. There are 2 important things you have to know. One is a classification. There are 2 types of classification, people. One is a GARBI and another one is a WHO. Okay, don't come to me T2 or T3. Okay, there are 2 types of classification. I am talking about the GARBI classification here. In the GARBI classification, water lily sign is seen in the T3 of GARBI. Okay, so honeycomb is seen in T2. T2 you may see honeycomb, and T3 you may see GARBI. Sorry, water lily sign. Okay, clear? In GARBI, T2 honeycomb sign and T3 water lily sign. While WHO, T2 you may see water lily. Okay, T2 you may see water lily sign. Some people put a T2 and some people put a T3 and they confuse and they ask again and again. Okay, I have seen this as a T2 in some books, sir. I am having a doubt. Remember, there are 2 classifications. One is a GARBI classification and WHO classification. If they are giving you water lily sign, if they are asking you staging, look what classification they are asking. They never ask without a classification. Clear? Clear? If it is a T3, GARBI, water lily is mentioned, T3. If it is a WHO, water lily, T2. Honeycomb is only seen in GARBI, which is T2 stage. Clear?
Yes, sir.
Okay. So organism is Echinococcus granulomatous. Organism is Echinococcus granulomatous. So benign and malignant tumors of liver. Most common benign tumor is hemangioma. Associated with steroid hormone is hepatic adenoma. And apart from that, malignant is HCC. Most common primary malignant tumor is HCC. Most common cause of death in HCC is cirrhosis. And it is the only one which do the venous spread. There are only two cancers which does the venous spread. One is this HCC, another one is this RCC. What are the two cancer which does the venous spread? Hematological, especially venous thing. Which one is doing? There are only two cancer will do that. HCC and RCC. Renal cell and hepatic cell. Okay. And tumor marker, most commonly AFP. This has been asked for almost like 10 times. So no, they won't ask. If you're lucky, they may ask. Okay. And staging here, Barcelona staging and CLIP staging and CUPA. Okay. Chinese University Prognostic Index. Okay. This is a HCC. And whenever the patient progresses to HCC, the only way is to do the liver transplantation. And in the liver transplantation, so there is a criteria. The criteria for the liver transplantation is this Milan's criteria. Milan is in Italy. Yes or no? So Milan's criteria, capital of Italy. Again. So what is the criteria for the liver transplantation? Milan's criteria. What is the criteria for the Milan liver transplantation? Milan's. Okay, what is the cold storage time for a liver, donor liver? We have studied that in trauma, no?
6 hours.
What is the cold storage timing? Someone is turning pages. Less than 12 hours and maximum cold storage time is 24 hours. Okay, less than 12 hours and maximum cold storage time is 24 hours. Do liver have any age in transplantation?
No.
Age limit for transplantation? No age limit is required for liver transplantation. Okay, have you ever heard about the, what do we call it, Hercules? Story of Hercules. The god punished him by cutting a piece of a liver, and then they turn about they come to know about the power of pluripotent. Because Hercules was offered as a punishment that a part of liver should be taken up, cut off and feed it to eagles. And every day the eagle comes, there is a new liver will be there. Yes or no? Because the liver is having a tremendous amount of regeneration capacity. But still you are making a cirrhotic, that means it is on your hand. So don't drink too much and don't make your liver, don't spoil your liver. Okay? So liver, Milan's criteria, size less than 5, 2 to 3 lesions less than 3 centimeter, and no gross vascular invasion. Then this is a criteria suitable for liver transplant. Only the named criteria are important. And liver failure classification, here, this one is important because they have asked several times in FMGE. What are the components of modified child puke classification? BAPI is the mnemonic. BAAPI. Bilirubin, ascites, albumin, PT, encephalopathy. Bilirubin, ascites, albumin, PT, and encephalopathy. BAPI. Okay. And MELD scoring, CBI. Creatinine, bilirubin, and INR. And PELD scoring, this is a BANIA. Those students from the Russia and Kyrgyzstan know about the Banya. It's kind of like a place where they have the hot air. Yes or no? Banya, bilirubin, albumin, nutritional status, INR and age. Nutritional status, INR and age. So the Banya is a PELD, CBI is MELD, BAPI is modified child puke classification. Okay, that you have to know. And speaking about the pancreas, acute and chronic pancreatitis, acute, most common cause is gallstone, and you may see the variety of signs. The names of the signs are pretty important. Mohammed prayer sign, Grey Turner, Cullen sign, Fox sign, sentinel loop of jejunum, and colon cutoff chain. Okay, colon cutoff chain. Whenever the patient comes to you with the acute pancreatitis, the first thing you have to do is the CECT. Okay, CECT, and you have to make them the NPO, and you have to give them the IV fluids of ringer lactate. Okay, and for a pain management, because patient will be having a tremendous pain, the pain management will be metamizole. The pain management will be metamizole. Okay, so we had this once in the COVID time, maybe 2 years back, we had a patient who comes for the abdominal pain, nausea, vomiting, fever, breathlessness. So what happened was we screened him and he was COVID positive, and most of the time we had focused the abdominal pain might be due to the COVID. So we have neglected it because he was he was having a pain and he was having this lung infection, and he was not feeling any taste and all. Typically look like a COVID symptoms. And we treated him for COVID for 2 weeks. He became COVID negative and he went back. And on the same day, he came back again with a severe abdominal pain. Okay, severe abdominal pain. Okay, let's do the CECT because we need to find the cause for the abdominal pain. No. Okay, we did the CECT abdomen and we were so shocked because there are two findings which have been seen on the CECT abdomen. What are they? One is this acute pancreatitis, another one is abdominal aortic aneurysm. Okay, there are two findings which came in the CECT. One is this acute pancreatitis, another one is abdominal aortic aneurysm. Because we did a CT angio also for this patient, abdominal angio. So we come to know immediately we did a clipping surgery and we put him on NPO. His acute pancreatitis has been settled down and he went back home. Sometimes you miss something and that comes as a very serious complication. You see? Yes or no? We neglected his abdominal pain and then we come to know that this is very important in this case. So never neglect acute symptoms. When patient says something, you should always focus on it. Okay, he's diverting you there to the clue, diagnostic. Okay, you should always remember that. And chronic pancreatitis, the DM plus steatorrhea plus calcification. Named criteria is Rossman and Cambridge. And the diagnosis is ERCP is a gold standard where you see the chain of lake appearance. Chain of lake appearance. Surgery we do here is a Whipple's procedure. Okay, surgery we do here is a Whipple's procedure. Okay, we have done a main 80% of surgery. Last minor area we have came is your urology and breast surgery. Okay, so speaking of the urology, just give me the okay, I know I'm occupying plenty of time for you, but I don't want to trouble you any more day. Just a little bit. Okay, try to focus your energy. Okay, understand? Shall we move on to urology, people? We done with the GIT. Shall we move on to urology?
Okay, sir.
Okay, just little bit, adjust. So first thing is your stones, kidney stones. So depending upon the pain, depending upon the hematuria and the site of bleeding. So bleeding present at the act, then the injury is the urethra. Bleeding appears towards the end of the act, then it is a bladder one. If the bleeding is intimately mixed throughout the process, it could be a kidney one. Okay, if the urine contains the blood also, then it could be a kidney one or pre-renal or bladder one. If the bleeding appears towards the end of the thing, then it is a vesicle. If the bleeding occurs at the act, then it is a urethral one. Now, speaking about the classic symptom of stone. Speaking about the classic symptom of stones. So, speaking of a symptom of stones, we are having a most common renal stone is your calcium oxalate that we will study that later. So, speaking about the symptoms, whenever the pain is from a low into testis, then the stone is at the PUJ, people. Okay, depending upon the pain the patient complains, we can identify where the stone is. If the pain is from the low into testis in males, then the stone is lodged in PUJ, pelviureteric junction. Okay, if the pain is from the McBurney's point, then you may see the mid-ureteric stone. Mid-ureter, the stone is lodged on the mid-ureter. Okay, if the pain is on the inner thigh and groin, then it is a lower ureter. Then the stone is on the lower ureter. If the stone is on the, if the patient is having a strangury pain, then the stone lodged in ureteric musculature. Lodged in ureteric musculature. Okay, low in to testis, it's a PUJ. And what do we call it? Pain from McBurney point mid-ureter, inner side of thigh lower ureter, and the strangury pain ureteric musculature. Strangury pain, you may see the ureteric musculature. Now type, most common type is calcium oxalate. Most common type is a calcium oxalate, also known as mulberry stone, aka mulberry stone. You know that already. And next is a phosphate one, aka struvite stone, or stagon stone, or jack stone. Struvite or jack or stagon. I used to remember the phosphate stone as a 3P. pH is alkaline, and it is a phosphate, triple phosphate stone, and it is associated with the protease infection. Okay, 3P's you always remember. pH is associated with alkaline pH, phosphate, and protease. Okay, uric acid is radioleucine, and cysteine calculus, it is on removal it will be pink, and when exposed to air it will turn into green. When exposed to air it will turn into green. Okay, and in a AIDS HIV patient or whomsoever is on the ART, antiretroviral therapy, then they may see the indinavir stone, because indinavir is a retroviral which we used to prescribe for the AIDS patient, and this can able to accumulate and lodge a stone. Okay, what will be the management, ESWL or PCL? Okay, prior moving on to that, nowadays these type of picture based questions are happening. So calcium oxalate, dumbbell fluorescent, if it is an envelope, either you may see any of these two picture in the urine microscopy, and for a struvite stone it will be like a coffin lid. Okay, there will be an outer and inner, there will be a green. Okay, uric acid rhomboid shape, and cysteine will be the hexagonal shape. Cysteine is a sulfur stone, sulfur containing stone, which will be pink in color. On when exposed to air it will turn into green. These are some drugs which can cause stones, but that is not necessary for you now. Maybe in future you may remember. Now the surgical management could be ESWL or PCNL. So ESWL is extra shockwave lithotripsy, and PCNL is percutaneous nephrolithotomy. Okay, ESWL is contraindicated in pregnancy. So what we do technically in ESWL is we pass the sound wave, we break the stone into powders, and that will be eliminated in urine. Okay, so pregnancy, because of we pass the sound waves or radio waves, which is contraindicated in pregnancy because of teratogenic effect. It may cause a bleeding sometimes because the normal tissue will be affected, or it may cause the powder may obstruct. That is so called as Steinstrass. That is the most common complication. Steinstrass in Greek it means stone street, where the stones will be broken by the ESWL, where it get accumulated in the distal ureter and obstruct the urinary outflow. Okay, so and it is contraindicated in cysteine stone. Already renal is obstructed. When you try to powder it, it will cause a more obstruction. This is the most common complication, and this one is contraindicated in cysteine stone. Okay, because it's a sulfur containing stone. When you try to break it, you will have the injury because of the sulfur reaction. So for those sulfur containing stones, you have to do the PCNL. PCNL is used for or indicated for two things, because it is an invasive procedure. We don't do that. One is for diverticular stones, another one is for larger stones more than 2 centimeter, diverticular, larger stones, and cysteine stones, and failed ESWL, sorry, and failed ESWL. So that's all about the renal stone. Most common renal stone, what is that? Most common renal stone, what is that, people? Calcium oxalate. Which one is associated with the protease infection, people? Faster. Which one is associated with the protease infection?
Phosphate.
Phosphate stone, or struvite stone, or stagon stone. Okay, ESWL is contraindicated in pregnancy, bleeding, obstruction, and cysteine stone. Most common complication is? Most common complication of ESWL?
Vein stays.
PCNL is indicated for 4 conditions. What are they? Stone in diverticulum, larger stone, that is stone greater than 3 centimeter, 2 centimeter, and cysteine stone, and failed ESWL stones. Okay, this is all about the renal stones. Now, renal cell carcinoma, as I said, it is also a hematological spread And most common distant metastasis is lungs. Most common type is subtype is clear cell carcinoma. Most common subtype is clear cell carcinoma. Most common type in hemodialysis patient is papillary. Sickle cell is medullary. The sickle cell trait was asked several times in FMGE. Most common RCC in sickle cell trait is medullary. Most common type is clear cell. Well, you may see the triad of symptom. RCC triad: hematuria, abdominal mass, and abdominal pain. Pain, mass, and hematuria. While Wilms tumor, it's children with chromosomal 8 and 11 defect, the same symptoms will be there. Instead of abdominal pain, you may have the pyrexia. Pyrexia, abdominal mass, and hematuria is seen in Wilms tumor. Whenever you see a child with the painless hematuria, typically it's a Wilms tumor. You want to write it as a note or anything, you can write it. They will write with the child with the painless hematuria and a palpable abdominal mass. This is a word they give you. This is the word they start with you when they go for the Wilms tumor. What is that? A child with the painless hematuria with the palpable abdominal mass. Clear? It's clear statement to Wilms tumor, people. It's a clear statement to Wilms tumor when they commit to it. Now, next is an important X-ray finding. So here you may see the blunting of calyx, and you may see the thimble bladder, blunting of calyx and thimble bladder. What is this? Does it ring any bell? Does it ring any bell, people? Blunting of calyx and thimble bladder.
Stone.
TB, genitourinary TB. IVP shows blunting of calyx and kidney. What type of kidney you may see? Putti kidney. What is that? Putti kidney. And a bladder. What type of bladder you may see? Thimble bladder. And what type of ureter you may see? Golf hole ureter. What is that? Golf hole ureter. Clear, people? Genitourinary TB. Most common site is kidney. IVP shows blunting of calyx and putti kidney, golf hole ureter, and thimble bladder. 3 signs you have to remember in terms of genitourinary TB. Then, speaking about that, you are having this drooping lily sign, which is associated with ectopic ureter. Drooping lily sign is associated with ectopic ureter. And here you may have this cobra head appearance. Cobra head appearance, which is seen with the uretrocele. And this one is a flower vase appearance because it looks like a flower vase. So flower vase appearance. What is that flower vase appearance? Does it ring a bell?
Horseshoe kidney.
Flower vase appearance. What was that? Horseshoe kidney. What is the most common fusion? Where do you see the most common fusion?
Inferior.
Inferior fusion is most common. Most common area is inferior fusion. Very good, people. Oh, that's the picture-based question that you have to remember. Apart from that, IVP shows a spider leg appearance. Apart from that, IVP shows a spider leg appearance in adult polycystic kidney disease, PKD. Spider leg appearance in PKD. Okay, we do the Rolsing operation for that. That is not necessary. So apart from that, you may see this prostate gland and the seminal vesicle. So speaking about this prostate gland and the seminal vesicle, you may see this 5 lobes and 3 zones. Posterior lobe is associated with the cancer prostate, and medial lobe is associated with BPH. And 3 zones, horizontal zone is associated with cancer prostate, and a transitional zone is associated with BPH. So BPH, transitional zone, and medial lobe. Cancer prostate, horizontal lobe, horizontal zone, and posterior lobe. Transitional zone was asked several times in FMG. Okay. Procedure is always TURP. Most common complication is retrograde ejaculation. Okay. Most commonly for BPH, we do the TURP, and most common complication is retrograde ejaculation. What is the medical management for TURP? Sorry, BPH. Old man, 50 years, comes with the constant inability to pass urine. He says his bladder is not always emptying. He always have the urinary sensation. What is that? BPH technically. And you do the ultrasound on this patient. Prostate gland shows a 30 cc of volume. That is an alarming sign, or you should initiate the treatment. Okay, you do the 30 cc of prostate gland, you see on the ultrasound, and you are diagnosing it as a BPH, and you are ordering a PSA. PSA is within a limit, so it is not technically the cancer. Okay, fine. And why the patient is having a urinary sensation? Because the prostate is enlarged and it is compressing the pathway, so urinary bladder is not emptying completely. That is common, I understood. So you are planning for the TURP. So most common complication you do is retrograde ejaculation. But what is the medical management you do for the BPH with the old age patient? BPH with the old age patient. What is the treatment, medical treatment?
Diazosine.
Tamsulosin, prazosin, doxazosin, tamsulosin, alfuzosin, anything. Tamsulosin 0.4 mg HS, you have to write it on the prescription. Okay, you should always remember that. Okay, so apart from that, hypospadias, most common type is glandular. Epispadias opens at the dorsum of penis. Opens at the dorsum of the penis. If the dorsum of penis has opening, epispadias, and if there is a ventral side, it is a hypospadia. Most common type is a glandular one. Then penile fibromatosis, Peyronie's disease, you do the Nesbitt operation. Very, very important. Varicocele, you do the Palamo operation. Torsion testis, pain very severe. Acute severe testicular pain. Acute severe testicular pain associated with bell clapper deformity. Investigation of choice is always color Doppler, where you may see Prain sign, or angel sign. Prain sign or angel sign. Okay, this is what you may see in this patients. Now, moving on with that, urology was done. Important things about the urology was done. Now we move on to the breast and thyroid gland. So speaking about the breast thing, so breast is a modified sweat gland, people, which is supplied by intercostal nerve, and there is this enlargement of the sebaceous gland around the nipple. We used to call that as a Montgomery tubercle, and this Montgomery tubercle is associated during the pregnancy. Okay, and the lymph node of breast is very, very important, because nowadays they are asking this as a what do we call it? This as the MCQ. So this is a level 1 and level 2 and level 3. Okay, level 1 is associated with the 3 groups: anterior, posterior and lateral groups. Anterior, posterior and lateral groups. We used to call that as APL. While level 2 is associated with central and rotors. Central and rotors group. Central and rotors. While level 3 is associated with apical node or apical ones along with the Guiliano. And the Guiliano is a one which is so called the sentinel lymph node of breast cancer. There is a sentinel lymph node. You should remember. Okay, and then we have this triple assessment, which is a radiological, and which is a physical examination, radiological and lab assessment. Physical, radiological and lab assessment. All triple assessment is done for cancer breast. Very, 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 very important MCQ. CA breast. Okay, then you are having this nipple discharge. White nipple discharge, which is a milk. What are the conditions you may see the milking? What are the conditions you may see the milking, people?
Prolactinum.
Pregnancy, post-lactating. Why always thinking about pathology? Think about normal physiology. Lactating woman. Yes or no? Will the lactating woman have a whitish discharge or not? Galactoria or not?
Physiology.
Yes. I think yes. Lactating breast. Then you go for the pathology. What is the pathology?
Prolactinum.
Prolactinoma. Prolactinoma. And yellow color is associated with the exudate, which is technically the pus. Abscess or pus will be there. And the greenish discharge is associated with
Duct ectasia.
Very, 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 very important MCQ. You have this picture on the next slide. I will show you. And blood is associated with
Cancer breast.
bloody discharge, cancer breast or duct papilloma. Duct papilloma or cancer breast. Very, 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 very important MCQ. Another. Okay, and then you have the superficial venous thrombophlebitis. Superficial thrombophlebitis of your breast vein. This is a Mondas disease. Here you may see the superficial thrombophlebitis. Superficial thrombophlebitis of your breast vein is associated with Mondas disease. The definition was asked several times in FMGE. What is that superficial thrombophlebitis of the breast vein called as? Mondas disease. Okay, so we see the duct ectasia, greenish discharge associated with the smokers. This is a greenish discharge associated with the smokers. Periductal inflammation will be there. You may do the mammography and you may do the heart-filled operation. 3 years back, I had this duct ectasia case. Very, very rare. Maybe for me it's rare because I'm a physician, but for surgeon, the plastic surgeon or maybe the general surgeon, they may get more cases. Okay. And apart from that, you may have this fibroadenoma. So fibroadenoma is nothing just the breast mouse. Nothing just the breast mouse. Movable, I rather say like a movable, painless lesion is so called as fibroadenoma, which develops from the single lobule, hormone dependent one. It could be the multiple ones or it could be bilateral too. Mostly we reassure if the adenoma is very big, then we do the surgical. Okay, and that too we do the incision. We do the Gallert-Thomas incision or periareolar incision or radial or curved incision we will make. Okay, then we are having a drugs causing gynecomastia. Disco FM is a mnemonic. DES, digitalis, isoniazid, spironolactone, steroid, cimetidine, cisplatin, CCB, captopril, clomiphene, ketoconazole, estrogen, OCP, flutamide, furosemide, and metrogyl. Mug up stuff, people. You have to mug it up on your own. Okay. So this is a drug causing gynecomastia. I used to remember with Disco FM. I used to remember it with the Disco FM. And then we go for the cancer breast. Most common site is upper outer quadrant. Very, 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 very important MCQ. Apart from that, you have this Paget's disease. I have the Paget's disease picture in the next slide also. This one is a Paget's disease, which is an invasive one. And apart from that, you may have this medullary carcinoma, tubular carcinoma, and a mucinous carcinoma. Okay, all these things are invasive breast carcinoma, while the in situ ones are DCIS and LCIS. This is a ductal and lobular carcinoma. So there are 4 types of DCIS. Among that, solido and comedo lesions are high grade. This one was asked several times. Okay, this one was asked several times in FMGE. Okay, and apart from that, in LCIS, you may see the Indian file pattern. This is an Indian file pattern, people. This is this Indian file pattern. You see this picture, which is a straight line. This is this Indian file pattern. It's seen in LCIS. Okay, next is a TNM staging. The only TNM staging you have to remember is the breast. Among that, Pierdo oranges appears in T4B. Pierdo oranges appears in T4B, and neighbor distant metastasis occurs in M1, and ipsilateral infraclavicular lymph node is occurring in N3A. Okay, ipsilateral infraclavicular lymph node is occurring in N3A. Ipsilateral axillary is occurring in N3B, and ipsilateral supraclavicular is 1,3C. Infraclavicular A and supraclavicular C, and axillary is B. If you remember this, then that is more than enough. And the sentinel lymph node for cancer breast is Giuliano. Okay, then you are having the investigation. Investigation highlights, very, 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 very important, straightforward question. Women with a dense breast, it is a USG. Women with a dense breast, it's always USG. Screening, more than 40-year-old female, mammography. Nowadays, UK is preferring more than 35 years screening of mammography. India is preferring more than 40 years of screening of mammography. Okay, and women with the implants, you always do the MRI. And investigation of choice for duct papilloma, it's mammography. investigation of choice for cystosarcoma phylloides, it is FNAC. Okay, cystosarcoma phylloides, it is FNAC. That was very, very important. Okay, and then surgical procedures. What are the structures removed? For a Halsted, we remove the axillary vessels, Bell's nerve, long thoracic nerve, which is a Bell's palsy, and then cephalic vein. While modified radical, we leave this nerve to latissimus dorsi and pectoralis major. We leave in modified radical mastectomy. We'll cut off in a normal radical mastectomy. Very, 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 very important. Okay, the pectoralis major cannot be cut off in modified radical mastectomy, while it will be cut off in radical mastectomy. Very, 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 very important. Okay, cephalic vein and Bell's nerve, axillary vessels, and nerve to latissimus dorsi, pectoralis major are preserved structure in your modified radical mastectomy. Okay, now, so apart from that, you are having this phylloides tumor, unilateral one, 40 to 80 years, and only the surgical excision will be used. And the flap we use for the phylloides tumor closure is a tram flap. Okay, then gene responsible will be BRCA1 and 2. BRCA1 is 17q and BRCA2 is 13q. And classification, Bloom-Richardson criteria will be used. Bloom-Richardson criteria will be used. Then thyroid. So speaking about the thyroid, follicular adenoma, investigation of choice is FNAC. Always do the FNAC, but never do FNAC in terms of only one cancer. What is that cancer you don't do the FNAC? Faster, people. What is a cancer you don't do the FNAC?
Medullary.
Medullary carcinoma, you don't do the FNAC? Or follicular carcinoma?
Follicular.
Follicular or medullary?
Interesting.
Follicular carcinoma, we do the core biopsy. Okay, follicular carcinoma, we do the core biopsy over the FNAC. Okay, keep that in mind. Okay, very good. Whatever I see, I expected this answer, so it's fine. So anyway, solitary nodules is associated with the adenoma, and inflammation, Hashimoto thyroiditis. Thyroid swelling will be associated with the DQ-Irvine thyroiditis. Treatment is always steroid. Okay, and if the thyroid is having a hard fixed mark, then it is a radial thyroiditis. Okay, radial thyroiditis. Okay, so do one thing. Whenever there is a lateral mass on the neck, do FNAC. And if it is a normal thyroid tissue, then there is a high chance that it might be the papillary carcinoma. And if the patient is having a pressure symptom, look for the Pemberton sign. Okay, if there is a Pemberton sign, then it might be the retrosternal goiter. Okay, retrosternal goiter. And speaking about the tumors, follicular adenoma, it is benign. Follicular carcinoma, it is malignant. So we prefer a core biopsy over FNAC in follicular carcinoma. And we may see the thyroglobulin antibodies in the follicular carcinoma. While the papillary carcinoma, you see this Samoma bodies and orphan Annie I. Okay, and you may see the metastasis to bones and lung. There is only two things you have to remember: positive berry sign, orphan Annie I, and Samoma bodies for papillary carcinoma. While core biopsy, positive thyroglobulin in case of follicular carcinoma. And medullary carcinoma, it arises from the C cells. So you may see the red oncogene mutation. Okay, red oncogene mutation, medullary, Samoma bodies, orphan Annie I, papillary, positive thyroglobulin with the core biopsy, history of radiation, follicular carcinoma. Clear? Then important condition and the named surgeries, which is your cyst trunk operation for thyroglossal cyst. Cyst trunk operation for thyroglossal cyst or fistula. Cyst is most common site is suboioid. And multinodular goiter, subtotal thyroidectomy. Follicular adenoma, hemithyroidectomy. Follicular carcinoma, total thyroidectomy plus lymph node resection. Papillary carcinoma, hemithyroidectomy plus ipsilateral central lymph node dissection or total thyroidectomy. We will do. Okay. So the last portion is burns. We apply the Wallace rule. So Wallace rule for adult, head carries 9, each upper limb carries 9, and so that it will be 18 plus 9, 27, and front carries a 9% and back carries a 9%, so that comes under 18. So that 5 9s are 45, and again you may have this abdomen which covers for a 18%. So again that is a 2 9, which is around like a 63, and lower limb 18, and you have this genital area 1. You can calculate the percentage of 1s. So head 9, upper limb 9, lower limb 18, front and back 18 and 18, and genital or scrotal region it will be 1. Okay, and in the case of children, everything is same except the head portion will go for the 18, while that 9% comes from 4.5 from each lower limb. So lower limb will have a 13.5 and head will have 18, while upper limb will have a 9 on each, and front have 18, back have 18, and genital area 1%. Okay, so this one is a Wallace rule of 9. And speaking about the Wallace rule of 9, we use it as a fluid burn patient. We do the fluid management by the Parkland formula, 4 ml into TBSA into body weight. So among that we can calculate the ml. Among that 50% should be given in first 8 hours and 50% in next 16 hours. Okay, 50% in next 16 hours. And the most common subcutaneous neoplasm is lipoma. Okay, then you are having this men 1 and men 2A and men 2B. Men 1 is 3P, 2P and 1P. Okay, men 1 is 3P, 2P and 1P we used to remember. Okay, I don't want to move with the more and more stuffs to you people. So we will finish up here.